Good morning, everyone. Maybe good afternoon or good evening, depending where you're from. Uh, Let me just put my timer on so I don't go over here. Hold on one second. Um, Good. Uh, I'm Glenn Pfeffer. I'm an orthopedic surgeon. Um, I work at Cedars-Sinai in Los Angeles in the Department of Orthopedics. I specialize in the foot and ankle. And most of what I do these days is CMT surgery. I'm co-director of the CMT program here. In terms of financial disclosures, I want to make very clear that I'm a full-time employee of the hospital. I don't get any money for each surgery I do. If I operate on one person, I get the same amount of money as I do if I operate on 10 or 15 people. And it's important for me to understand that. When my wife, who always helps me with these talks, listened to it, and she said, you really have to make people understand that you're not getting any money for this directly in any way, and you're doing it for a bigger commitment than that. There's a lot of things we'll talk about. Many of you know about the Instagram site I have. It's called Charcot-Marie Tooth Surgery, and you can find it. It's really very excellent, very educational, and supported by the big CMT groups, and you can talk to patients and learn a lot. Now, what I'm specifically talking about is the surgical correction of cavo varus foot. One day, I won't be needed for a talk like this. I predict that CMT will be cured or made a lot better for the patients who have it. But at the moment, surgery is one of the great tools, along with bracing, that can help patients immediately live a better life. Now, what is cavo varus? Well, 70% of patients have this cavo varus foot. It can be mild in a CMT patient. It could be more severe in a CMT patient. This is a brother and a sister. What's interesting is that a mild deformity can affect somebody very poorly sometimes, and while a more severe deformity may be tolerated better by somebody. So there's not a direct degree of severity to symptomatology. And I say that because patients often call me up, or we video chat, and they go, I'm not as bad as a lot of the patients on Instagram. Maybe I don't need your help. You know, you need help when your symptoms warrant help. So cavo varus. Cavo is the high arch, like a cave. Varus is the medical term for the interning of the heel. Look at your foot, for those of you who are on now. Do you have that cavo varus foot? 20% of CMT patients won't have this, and they'll be paralyzed below the knee, or very, very weak in all the muscles below the knee, and they'll have a flat foot. It doesn't really move very much, but it is flat on the ground. So what causes the high arch cavo varus? Well, the flat regular foot in a CMT patient is caused by paralysis. The foot can't move and it's not deformed. But in a CMT patient, think of this horse, which many of you have seen before. If the reins, let's say, are muscles and they're pulled evenly, the horse goes straight. But what if one of the reins is pulled harder than the other, or one of the reins is cut? You'd end up with the horse going in a cockeyed direction. And that's what happens with CMT. Some muscles in a patient can be very strong, and some can be very weak. And a deformity starts to develop in that extremity. Now, this is an example of a gal who has absolutely no muscle function below the knee. She has what's called a flail foot. But you can see the advantage she has in that her foot is flat on the ground. She can't walk without holding onto a wall, but this is a perfect type of person for a brace. And AFOs, ankle foot orthoses, or braces, as all of you know, can be just life-changing for the right patient. With the brace, she's able to walk briskly through the hall and have a terrific life. This is somebody who would not be a candidate for surgery and would never consider having surgery. And there are many braces like this. You don't have to have custom braces. That may be best for you, but not necessarily. Just remember there are a lot of different types of braces. And just like you can't accept one dress or one shirt to fit everyone, ideally you like to try different braces to see which is best for you and your problem. Now, an AFO, as I've just said, is wonderful. And it's wonderful, particularly for someone whose foot is flat on the ground. It's planted right. Someone who's paralyzed below the knee, or someone who's very weak. These are the patients who need AFOs. Now, this is not the kind of person who wants to have an AFO or needs to have an AFO. This is what I call the crooked foot. Right? Here's an example of somebody with a crooked foot that's been told that the only way to really get through life is with a brace. Why are they told that? I don't know. Perhaps people didn't know any better. Perhaps the patient couldn't be convinced that surgery would be the best option. But crooked feet in braces, feet that can't be brought to a flat position, hurt. They develop calluses in the areas where bones are prominent. People walk on the side of their ankle, underneath the fifth metatarsal, at the base of the fifth metatarsal. If any one of your feet looks anything close to this, you don't need a brace. You need an operation to help you. To put a foot in a brace like that is like trying to put a round peg in a square hole. It's just not the right way to go. And I see this every week. Someone comes in and I'll say, why haven't you been offered an operation? And they'll say, well, my neurologist doesn't believe in it. The person making my braces thinks it's too risky. My mother's worried. Maybe I'm too old. Hogwash. You need a foot that's flat on the ground.
Hi, my name's Alma, and I'm gonna have surgery with Dr. Pepper. And like he always says, you can't put a crooked foot into an AFO or a brace. When I first got it, I was very excited because I thought, okay, this is gonna work out perfectly. But it actually just causes more pain because my foot is crooked in it. You would think that it would be helpful, but it's not. Cool.
This is a video I got from Australia. She couldn't find anyone to operate on her. Unfortunately, she couldn't come to Cedars. I get videos like this every single day of the week from around the world. I just got a video from someone who has a foot worse than this, who's in Ukraine. And she said, please, can you help me come to the United States for surgery? One day, what I think I'm going to do is spend 6 months and travel around the world and do CMT surgeries, but more on that later. Now, what happens? This young fellow is probably about 13, 14, and people are given braces and they learn to live with them. They have a crooked foot and a brace, they're painful, but what else are you going to do? We all have problems in our lives, and these people don't know any better, or they're scared of surgery, so they've not been told anything else, so they live with it. Here's a great gal from the Midwest who's involved heavily with the CMTA. And she said, well, I've done well in my life with these braces. But then she got to the point where she couldn't make it anymore. And we operated on both her feet. Here's a 36-year-old who's had 3 surgeries, all done elsewhere. She's scared to have surgery on her foot for CMT. She said that she never met anyone who was confident that could help her. The problem here is that she's already now developed arthritis in her ankle. You can't walk on such a crooked foot, even in a brace, without developing problems. And many of you who are listening to me today know what they are: chronic pain, falling, ankle arthritis, stress fractures, depression. Don't accept a foot like that for yourself. If you're wondering why I feel so passionate about this, is typified by this video, which just breaks my heart. This girl was told that there was nothing to do for her at the age of 12 years old.
So you can see how stiff her foot is. It just isn't a braceable foot. And yet, she's been asked to wear braces and lives in pain.
Hi, my name is Jillian. I'm from Chicago, and I'm here in Cedars-Sinai to get my feet flat and have a surgery tomorrow. And I'm very excited, and I hope it turns out very nicely.
It's going to turn out beautifully.
Please don't be like Jolene. Don't be like the other people I showed you. Don't brace a crooked foot. If for some reason you don't want surgery or can't have surgery because of medical conditions, that may be the option that's only available to you. But you can do so much better. Get that foot flat. Now, there are risks of surgery. There are risks of this bungee jumping. You'd never see me doing this. Be chicken. And so surgery has certain risks, and you have to ask yourself, is it worth it? It's not worth it for me to just parachute. It's not worth it for me to bungee jump. I have 8 people that I know of out of almost 800 surgeries now that have not done well. 1 or 2 of them is because of disease progression. 1 had a bad infection, and the others were overcorrected. I actually took a high-arched cavo varus foot and turned it into a flat foot. That's not happening anymore, and it happened during a transition when I was developing new techniques for very severe, complex deformities that no one in the United States was able to treat effectively without a triple arthrodesis or multiple fusions. So we've learned, and those people who've not done well because of overcorrection, at least half of them have been reoperated on and will do well. So the right foot has been operated on. The left foot hasn't. Now there's a straight foot and a crooked foot. We're going to have a great honor of talking to Sarah. Here she is on the left side before her surgery. I met her when she was 16. All I want, she said, Dr. Pfeffer, is to walk down the high school aisle to get my diploma and not have to hold on to my father. Let's just see here if this light will go back on. Maybe it's out. There we go. There we go. Sorry. Give me a sec. Okay. Well, we lost this light, but that's all right. We'll get by. Now, Kyle here from Kentucky, he'd had 3 surgeries performed elsewhere on his right foot. He couldn't live with the pain. He couldn't walk. He couldn't spend time with his children. He came. The surgery had been scheduled by a Zoom call, and I was able to figure that out. And he had the operation set, and I got a text from him the night before surgery. He said, Dr. Pfeffer, I've been prepared for many years to have my leg amputated. I live in so much pain. And if you think it's best, I want you to amputate my leg tomorrow during the operation. He said, I can't live with this pain anymore. This is someone who has a crooked foot that's been braced, and he lives in chronic pain. I promised him that I would make him better, which made it all that much more gratifying when just a few months ago, maybe 8 months after surgery, I got this video, and he said, thank you so much. I just walked through the snow with my children for the first time without falling and not having any pain. This is little May. What's most remarkable to me about May is that she lives in a major city. And she was told there's nothing to do for her foot. She was told that she had to live with it forever. Here she is 6 months after that operation, walking without braces and doing beautifully. This young man from Israel, both feet were like the left foot. We operated on the right. It's just a few weeks after surgery. The wounds are still healing. He may never get that much motion from his own muscles, but at least now he has a flat foot so he can stand and in a small brace walk, or maybe ideally without a brace. It takes about a year to recover from the surgery.
Hi, my name is Jolene, and I'm 12 years old, and I came here in Cedars-Sinai to get my surgery done, and my feet, it looks wonderful, and now it's flat on the ground, not like the other feet, and the other feet is like bad, and this side is now amazing.
How was the surgery?
It was great.
Did you have a lot of pain?
No, it wasn't that much pain.
The pain pump helped?
Yes.
So we'll talk about the pain pump in a while, but I thought you'd all want to see this. Everyone's always asking me for follow-up, and it's hard because patients come here for 2 weeks and then they leave, so it's hard to get videos. But she came back for her foot, This left foot was operated on 4 months before, and now she's here for the right foot. This was a young woman who was told there's nothing to do but to live in a brace the rest of your life with your crooked foot in chronic pain. So, what if the disease progresses, people ask me? That's certainly reasonable. We know that CMT is classically a progressive disease. The way I think of it is, if I see a patient and you're starting at a C+ with a crooked foot that doesn't move and a foot drop, if you do progress, God forbid, you'll end up with a D. But if I can get you to an A-, an A for a CMT foot, and you progress, you'll end up with a C+. That's, I think, very compelling for me and the patient to take the chance to make the foot better. But again, don't take my word for it. Go on Instagram, go on chat rooms, speak to people, look at the results of the paper that we'll be publishing. I think this is a very, very worthwhile surgery for almost everyone who has that cavovarus foot. What about my foot drop, people ask about? Clearly, that's a big issue. People trip over their foot drop, they knock their toes, they can't wear shoes. Well, braces are great for a foot drop. They help pull the foot up and they stabilize it. There are many good AFOs for that, both custom and off the shelf. But some people don't want to wear a brace. A big group of my patients are 15, 16-year-old people who know they're going off to college in a few years. They're wearing braces. They may be comfortable or not, but they say, I don't want to go to college in a brace. And most of the time, I can deliver on that promise, almost 90%. Now, what you need to do to sort out if you're a candidate to not be in a brace, because I can get your foot flat, but can I get your ankle moving up and down without a brace, is do you have a muscle that's strong? Do you see this person? They really have very little function in their foot, but look how strong they are at pulling the foot inward. All I need is your Achilles or your calf muscle to be working okay, and one other muscle. I just operated a gal from Canada. I must say I was really honored. It was a very unusual operation because she only had one odd muscle still working. She wanted to take the chance. She's 30 some odd years old. We did the transfer. She had to pay herself for it. But she did so well. She went back to the doctor in Canada and said, I want the other side done. He said, I never thought this could have worked this way. Let me work on this for you. And she got Canada to reimburse her for both surgeries. So I was pretty honored to have Canada paying us at Cedars-Sinai for an operation. This is what the operating board looks like. This is no small feat. There are 14, 15, 16 different procedures. We write these up on the board to make sure everything is done correctly and in order. Sometimes we have to fuse a joint. I'd rather not, because it's best to preserve as much motion as possible. But fusing one joint or even two, and if it's done well, is not a problem at all. We'd particularly like to avoid it in very young people because they have the most life to live, and you want the joints as supple as possible. You heard someone talking about the pain pump. We published several important articles this year on CMT surgery. This was on the pain pump. It's a little tiny catheter with a supply of numbing medicine that goes around the nerve. Every time you hurt, you push a button. I would say in 90% of patients, it's great. Sometimes it falls out, sometimes it leaks. But for most people, it makes the surgery almost a pleasant thing to have gone through. Here's
My name is Grant Lawler. I recently had CMT surgery on my left foot. One of my main worries was pain, and they recently started using a pain pump. The pain pump literally makes it to where I have hardly any pain, next to none. You press a button if you get some pain, and in 15 minutes, it's gone.
That's on the high end of doing well. Better than many, but still, I think that exemplifies the tremendous benefit of the pain pump that we started using. We've also been doing a lot of research on the complicated bony architecture and the twisting in the CMT foot, and this has been very helpful with advanced mesh analysis and 3D graphic analysis of the deformity. This was just published this year. All of the surgeries involve cutting bones and moving soft tissue to balance the foot. In this case, this is a heel model from the back, and we cut a wedge out of the bone. We bring that down, and then we can place the heel where we want it so that the body weight is more plumb line and the heel is not so cocked in. Surgeons find it very difficult to get this heel in the right position. And we now know why that is. Another paper, this is a wedge being taken out of the front of the foot. You can see that. And the goal is to get the foot flat, in a flat position. This was an internationally recognized paper that we published this year also, and it actually shows something fascinating, that patients who have had CMT for a long time, since childhood, because of the abnormal muscle pull on the bone's taken on a different shape. And that's why, without understanding that, surgeons can't get the bone into the position they really want to have it, and often accept compromise, or often say, well, we can't get the bone where we want it, we're going to have to fuse some joints. And I really disagree with that strongly. Now, many people don't want to see surgery, actual surgery. Some people do. For those who want to see one slide of a film clip, you can keep your eyes open, but for everyone else, shut your eyes tight. What we're showing here now is a surgery picture, a video, your eyes closed if you don't want to see it, of surgery. We're taking the tendons that are deforming the foot, the muscles, we're bringing them from the inside of the leg to the outside of the leg. This is orthopedics. This is what I do every week. And we'll take those tendons and put them onto the top of the foot. They will now start moving the foot up and down. Open your eyes. Trust me, everybody can open their eyes now. That's all we're going to show. Now, what other things surgery can do is we can help the toe positions. The person on the right foot has had surgery. The toes were very, very bothersome in a shoe, and we were able to straighten them out. The surgery is done with loop magnification on my eyes. We have a large surgical team that's very experienced. Sometimes the people change over the years, but our core group has remained stable. These surgeries are 4 or 5, sometimes more. That's why we need a large group. It really does take a village here to get this right. And we're now approaching close to 800 surgeries, which I am confident is by far the largest experience in the United States, and if not the world. And I say that only because with experience, I think for us comes some excellence and the ability to research these complex problems and understand them better. Here are the examples of an operation. And as you think, gee, do I want surgery? Assess it for yourself. The right's had surgery, the left's about to. The left's had surgery, the right's about to. We've cut bone wedges, we've transferred tendons, we've released soft tissues, we've tightened other soft tissue. The left's about to have surgery, the right's had surgery. And these are only a few months after the surgery. As I said, it takes a good year before people reach maximal improvement. This is a video I just took in the office. We fixed the right foot on this young fellow from Russia. The left is for Monday.
Здравствуйте, меня зовут Анатолий. Я приехал из России к доктору Пфефферу, и мы уже сделали первую ногу. Я чертовски счастлив, что приехал сюда. Правая нога выглядит замечательно, и я надеюсь, что мою левую ногу мы сделаем также хорошо.
I don't know what he said, actually. I hope it was good, but maybe many of you are listening speak some Russian. I think there are probably Russian viewers.
So try to move it up.
Now, this is the most amazing thing that I'm going to show you. This is just 2 weeks after surgery. We've moved a muscle that bends the foot in one direction and put it on the other side of the foot or on top of the ankle to get the ankle moving up and down. It's only 2 weeks out. I always wonder, will the brain get it? Will the brain understand that this muscle is working in a different way? Watch this video. This is very typical of what happens 2 weeks after surgery. And it's a miracle to me that the brain can do this.
So try to move it up.
She can.
Or try to move your ankle out to the side. There you go. Do it again. Oh, that's terrific. Congratulations.
Thank you.
That's great.
Good?
No, it's perfect.
Oh,
Okay, let's get the kit.
So what's happened is the muscle that was used to turning her ankle inward, now her brain learned how to use it to bring the foot
Other
upward.
one. If anyone is thinking about this, you have to do it. I can't believe what my foot looked like. I can't believe after the surgery how low my arch was and how straight my foot was. It's amazing. I can't wait to get my other one done. I can't wait to be done and walking. I can walk on sand. I can inspire my kids to get that we finally have options. We have options with CMT. And it's Dr. Pfeffer. Thank you so much. Yeah, and if anyone's second guessing this or anything, I just started this process. You got to get it started. Do it for yourself. Do it for your family. Do it for the people that help you get everywhere you go. Do it for everybody, because this is what I needed.
So CMT feet are different. They're as different as the people they belong to. Just because you're not that bad at deformity doesn't mean that you don't need an operation. And if you have a bad deformity, don't leave it alone, because it's just going to get worse. Big problems get small. There's no cookbook answer for it. We're changing things in the United States, but in general, if you speak to orthopedic foot and ankle surgeons, they have a cookbook answer. They'll say, well, this is what you do for CMT, but it's not. It's a very bespoke, individualized surgery with 15 different components that have to be balanced. Finally, what you saw in the beginning was this video, and this is going to, I think, change the way orthopedics, and especially foot and ankle and CMT, is done over the next 10 years. This is a real-time transformation of a mesh analysis of a foot that's been created and rendered in 3D. And what we're looking at is preoperative planning and how to change the foot. That ultimately will have AI and deep learning to accumulate a database that we can use, so that ultimately before an operation, I or perhaps another surgeon who's not as experienced will say, Siri or Alexa, what's the best way to correct this deformity? Well, Siri will say, there are 3 options, Dr. Pfeffer. Anyway, that's definitely coming. And I'm very excited about that. We're doing a project now with an international company and the engineering department at USC. So when should you do surgery? The day you wake up and you know you don't want to live with your feet the rest of your life is the day to do the operation. The day you look at your child's foot and say, I don't want my child to have a foot like that, is the day to do surgery. Big problems start small. Whether you're 6 or 7 or 60 or 70, get the surgery done if you have a crooked foot or a dropped foot that's causing you to be in a brace and you'd rather not wear a brace if possible. So thank you very much. That's me at Cedars-Sinai. I'm proud to say that Cedars was just voted the #2 hospital in the United States, and our department, the #3 orthopedic department. I'm certainly proud to be here. Now let's hear from Sarah, who you saw before. Sarah came in at 16 years old with feet on the left, and then she walked out probably about 9 months later with feet on the right. So how do I do this? I'll end this. Is there anything I should do?
Can you hear me?
Is that Sarah?
Yeah, hi.
Hi, Sarah. I haven't seen or heard from Sarah for 9 years. In preparation for this video, I thought, well, I'll give her a call and see how she's doing. I'll give her the floor now, but she said one of the most remarkable things to me that any patient has ever said, keeping in mind what her foot looked like, and she'd failed braces, she was in chronic pain, she couldn't walk at all. Sarah, right, she said yesterday, she said, there are many days that I forget that I have CMT.
Mm.
So how are you doing? Tell us about it. How's your journey been?
I am fantastic, and I have the life that I'm living is the life that I dreamed of having 9 years ago before the surgeries. So as a teenager, when all I wanted was to not wear big, chunky orthopedic shoes and braces to prom and walk at my high school graduation, That was all in 2013. By 2014, I was in college, traveling Europe, and walking all over cobblestone streets in regular shoes. It's the best thing that's ever happened to me.
What made you decide to do the surgery? Sarah showed up, and she's been emblazoned on my CMT memory forever because she had a very complicated problem. She was not a cookbook case. And her dad was a wonderful man who also had CMT, who I guess I'm allowed to say I just operated on for his foot 2 weeks ago. He said, Dr. Pfeffer, we've looked all over the United States for someone to take care of Sarah, and we've decided to come here, like no pressure, right? and I wasn't sure. What happened, Sarah? What made you decide to do it? And when you did, how long did it take before you got as good as you are?
I thought of it as the only option because I knew that nothing else worked, and I had seen other surgeons and they basically sent me away. So there's nothing to do, just get ready to suffer basically for the rest of your life. And I didn't want to do that. It broke my heart. When I would sit there and picture my future life, I wanted to be able to have kids and toddlers and be able to chase them around and, dance at my own wedding and things like that. And those are the things that matter to me. And so whatever it took to get to that point was absolutely worth it. And it took a couple months to really start, relearning how to walk. And because it was a series of surgeries, there were, a couple weeks here and a couple weeks there, and then another surgery and so on. But by maybe this started in 2013, and by 2016, I could walk 14 miles straight. So I would consider that full recovery.
So, a few years ago, the New York Times wanted to do an article on CMT, possibly. I thought that was very cool. And I thought of Sarah, and I called her mom, right? And I very sheepishly said, hi, Mom, not knowing what she'd say. How's Sarah doing? And I thought I might get lambasted. This is Dr. Pfeffer. Don't you ever call us again. Oh, my God. But her mom said, Dr. Pfeffer, are you kidding? Sarah's working in a pizza joint, right, for 8 hours. And she just walked around London with maybe your boyfriend then, or I don't know, in flat shoes. Do you work out? Do you do physical therapy still?
And actually, I was walking around London in high heels, which I never thought would be possible. It was the best. But I just go to the regular gym, and I don't think people can tell based on the exercises I do. I can just do almost any exercise I want. I can jump up and down. I can go downstairs one stair at a time. I don't have to go 2 feet on one step and then again and again. I don't go to physical therapy anymore. I definitely keep up on some of those exercises, but I don't need it. Yeah.
Well, I just want to say as a disclosure, because I think we have to finish up. Well, two things. One, I'm going to be at a lunch break. All your questions could be there. If Sarah has time, she'll be there too. Many of you will probably want to speak to her more. But again, I haven't talked to her for 9 years or so since yesterday. And when I got her text, I almost considered not asking her. This is really the high end of the bell curve. Not everyone can expect to be wearing high heels in London after that bad a foot deformity. So I almost didn't ask you to do it, Sarah. But as long as people understand, I think, I did a blog to Last Sentence with Elizabeth Ouellette from the CMTA. It was fun to do. And I remember at the end, I thought of a quote from a book I had read, and it said, hope is the last to die. And I love what I do because I see people who still have hope. And when I can give someone like Sarah back what she's gotten through her hard work, and well, that's worthwhile for everybody. So I think we're done, right? Anything I should do? Should I keep talking? Should I sign off?